So we've seen a variant product to axicabtagene ciloleucel, the X19 XTE CAR T cell for mantle cell. Now we're seeing axicabtagene ciloleucel for indolent lymphomas. And in both settings, we're seeing substantial activity. One of the concerns, of course, here is how sick were these patients? What were their expected outcomes? Unlike in the large cell trial where we were picking patients based on an important retrospective study, the SCHOLAR-1 study, that we know that the median overall survival of patients was only 6.3 months. Here we're taking a group of patients who are actually more favorable. 20% of patients didn't even have refractory disease. So it's a little bit hard to know. So obviously in a setting like this, the efficacy was great. There's no question. Efficacy was fabulous. We're seeing very good duration of response with limited follow-up. Okay, this is very early. Follicular lymphoma is the long game. It's not a short game. Median follow-up only 15 months. But, at 12 months, close to 80% of people were still in response among the responders. A little less exciting in the marginal zone. However, it could be a problem of small numbers because only 16 patients were treated. So we need to see some more data. But here it's all about what the toxicity is. This is axicabtagene ciloleucel. There was toxicity, far less than we see with large cell lymphoma. Why? Because we know how to manage the toxicity much better than we did in the early trials. So I think, in the community, when someone's faced with should we think about CAR T cells? I don't know if we've identified that patient like we have in large cell lymphoma that clearly is going to benefit from this and doesn't have alternative treatments that are very effective.